these two mixed up. When you hear the word projection, we're simply talking about what is the path that that X-ray beam is traveling. How does it enter the patient and then exit the patient? So when we say projections, we're talking about an AP projection, a PA projection, a lateral projection. We're simply describing how is the beam traveling through the patient. So when I say AP, for example, AP stands for anterior posterior. That means my patient is standing facing the beam enters the anterior surface, exits the posterior surface, thus AP projection. In reverse, PA, if the patient's sitting away from the tube facing the wall bucky, the beam enters the posterior surface, exits the anterior, thus it's a PA projection. Does that make sense?
Yes, sir.
Projection always refers to the path of that central ray as it passes through the patient to the IR. And we identify those projections by the entrance and the exit points. Then when we say position, we're talking about the overall posture of the patient. How are we actually positioning the patient? Are they standing up? Are they lying down? And more specifically, are they standing on with their side against the wall bucky? Are they standing with their chest against the wall bucky? Are they lying on their back? Are they lying on their belly? Are they lying on their side? These are all different positions that we're going to discuss. So it's the overall posture of the patient or position, and it's going to refer to the specific placement of the body in relation to the table or the IR. Table or the IR. And we'll define all those specifically as we move forward here. We got a lot of different positions that we're going to learn throughout our 2 years here, and a lot of different projections as well. You got some great pictures in your book that I have on the slides as well. They're a great way to visualize what I'm talking about. So once again, big stir on that. Make sure you know the difference between a projection and a position, because those terms can be used interchangeably. But you need to know on the question, am I referring to a projection or am I talking about the actual position of the patient? Really easy way to mix up questions.
Just to talk terminology, CR is?
CR is central ray. Right. All right, so two more here. You'll often hear people talk about views and methods. When we say view, that's the part that we actually see on the X-ray. So I'm doing a view of a hand, a view of a chest, a view of a foot, a view of an ankle, and so on. That's going to be the most preferred term you see used throughout the United States. So I hear people saying that word view all the time, but they don't necessarily use that word correctly. View only refers to the part that we're seeing on the IR or on the actual X-ray film. It's not used to describe a position. It's not used to describe a projection, but you'll hear text using that incorrectly. So what's going to view is what is the part I'm actually visualizing? What am I looking at? It's a view of a hand, a view of a head, a view of a chest, so on and so forth. And then method is going to be a specific radiographic projection developed by an individual. When we talk about methods, these are going to be like methods outside the normal methods. So you guys learned about PA and lateral chest yesterday, but there's specialized views. Those of you that were in lab, such as that lordotic view, y'all remember what that lordotic view was? Where you were leaning back? That's also called the Lindblom method. It's a method outside the normal way of doing it. It's a specialized process. So method is specific radiographic projection developed by an individual. Usually they're named by people, like Lindblom method, Waters method, things like that.
Like the Fong lateral or Wilson lateral.
The Wilson lateral, that'd be a method, correct. You've already heard about the Wilson lateral, okay. Yes.
Miss Bonilla, she told us.
Oh, she told you all the secret, okay. I
I
heard
keep
you
asking him to show us, but he won't.
It'll come with time. Can I do it? Oh, I do even better than the Wilson lateral. The Donahue lateral's got nothing on the, yeah, I mean, the Wilson lateral's got nothing on the Donahue lateral, let me tell you. You don't want me judging your laterals, trust me. I like them to be absolutely perfect.
So when you got lab test, is it just Mr. Palmer or do you have
It'll just be Mr.
You think
Fong.
you're ready for the
This
test
semester,
out?
next semester, you'll have Ms. Bonilla.
You think you're
or
ready
Mr.
for the
Fong.
test out?
You'll be in lab groups, so you're gonna be just with Fong or just with Bonilla, then you'll swap Fong semester. So you'll get one of those teachers for each of your lab groups.
Position?
For me, I'll be there for your capstone exams. That's the big, scary ones. That's a year from now. Don't worry about that right now. Don't stress about that right now. Just focus on the now.
So what do you mean by exact opposite of the second line that was exact opposite projection?
Exact opposite projection. So it's basically, when we say projection, we're talking about the path of the beam. This is not talking about the path of the beam. It's actually talking about what are we visualizing. It says opposite because a lot of people mistakenly use that in place of projection, but view is simply, what am I looking at? What's the part I'm looking at? No more complicated than that. Okay, so back to projections. These are some of our most common projections we're going to talk about here. I just described two of these, but AP, of course, AP stands for anterior posterior. And once again, when you see that word projection, the first thing that comes to mind should be central rays, the path of the beam. So once again, AP means I'm entering the anterior surface and exiting the posterior surface. That means you're typically facing the X-ray tube, whether you're lying down or standing up. You're looking straight at that X-ray tube. The complete opposite or reverse of that would be the PA, stands for posterior anterior. So our CR enters the posterior surface and exits the anterior. And typically that means you're either lying on your belly or you're facing the wall bucky, facing away from the tube. Then axial. Now we saw that word already. Where did we see that before?
Horizontal.
The horizontal plane, right? So don't mix that up with your horizontal plane. When we're talking about planes, it's referring to that slice, but when we talk about projections, axial means that the CR, or central ray, has been angled 10 degrees or more. We've angled that tube 10 degrees or more. You guys that manipulate the tube, you know how you can turn the tube, how you angle it, that's what we're talking about. So anytime we do an angled projection, typically in the naming of it, you'll see that word axial. So that should always be a little reminder, a little light bulb. I see the word axial in regards to projection, my tube is angled some kind of degrees. We have multiple degrees depending on what body part we're visualizing. It can be from 10 degrees to 20 to 30 to 40 to 50, so on and so forth. Just depends on what we're wanting to look at and what part of the body we're doing the projections on. So big star, once again, very essential terminology there in regards to projections. So once again, projections refers to that path of the beam. How's that beam entering my patient? How's it exiting my patient? So you'll see these in combinations. Sometimes there'll be an axial PA, axial AP, so on and so forth. If I said axial AP, that means I'm facing the tube. It's angled, it's still entering the anterior surface and exiting the posterior surface. Making sense? Good, good. All right, so if you saw a patient that was standing like that, the line is referring to the path of the beam. This is your wall bucky. Tube is over here. What projection are we looking at there? PA, posterior anterior, because the path of the beam enters the back, exits the front, hits our IR to make an image. It would be a PA projection, PA chest. Very good. What about this right here? We're lying down. Path of the beam is how that arrow is traveling.
AP, sir.
That would be an AP projection, correct. Very good. Does that make sense?
Yes, sir.
Good, good. Focus on those pictures. You're probably gonna see some similar pictures on your exam. I'm just saying. Question?
Is he supine or prone?
We're getting to that.
Yeah,
We're getting to that next. Positions are next. So focus on projections right now, but yes, that would be supine. All right, so a few more essential projections. If we see the word tangential, that means that the CR is directed along a curved body surface. The most common tangential projection we'll see is in views dealing with the skull. The skull is round, it's curved. If it hits that curved surface, that's going to be what we call a tangential projection. For now, know that by definition. We'll talk more about tangential projections when we get to Rad Pro 3. Lateral typically means the patient is in a lateral position, which means their side is closest to the table or the IR, and that's entering one side of the body, passing transversely along the coronal plane and exiting the other side of the body. In other words, it's entering one side, exiting the other side. That's a lateral projection. And typically, once again, usually the patient is standing with their side against the wall or their side on the table. Enters one side, exits the other. It can be either way, right side to left, left side to right. On most of your lateral projections, typically, unless it's, well, especially in the torso range, such as chest and abdomen, unless it's requested by a doctor in another way, typically your left laterals are the ones that you're most commonly going to do. That means that your left side is what's closest to that IR. Left side's touching the wall, left side's touching the table. So left lateral will be the most commonly ordered type of lateral projection in regards to the torso. And then obliques. Ooh, those of you that did obliques yesterday, how'd you like those?
They
A little
are
bit
right. You
confusing,
gotta
right?
work on your positioning, making
Little
sure
bit
that
confusing.
MSP and MCP line
Yes.
up and, ooh.
It's usually everyone's least favorite type of positioning to do, the
Especially
obliques.
the 45-degree
Yes.
measuring.
Did you guys, you want me to tell you a little cheat code?
Yeah.
Cheat code?
Is,
Did you look at the tiles on the floor?
Mm-hmm.
See how they're squares?
Mhm.
If you line your feet up at the corner, that's 45 degrees. But you didn't hear that from me. This is a little trick that, if you haven't, until you learn to eyeball it, it's a little trick you can use. Yes?
Mr. Fung helped us with trying to double check the angle, but it was just like using your hand. I would assume that's somewhat subjective. Does it have to be like 45 exactly, or just
Yes.
as close as we can get it?
Yes.
Okay.
Yes.
Cool.
45 exactly. And the reason being, that's a good question. The reason being, if it's not exactly 45 degrees, did he explain why you do an oblique on the chest? We haven't got to that yet in our lecture.
Sort of view.
What we're doing on an oblique chest is we're elongating the lung of interest. It distorts it so the doctor can get a better view. And if you don't have that 45 degrees correct, you're not going to distort it correctly. There's not going to be a good visualization of that stretched out lung. It'll be foreshortened. We want to have a nice stretched out look to it. But that's the next chapter. It's beyond this chapter. We're sticking with this chapter right now. But anyway, obliques, guys. That means that the CR is entering from the side angle. Entrance and exit surfaces are still specified. So we have AP obliques and PA obliques. And I'll specify 4 types of obliques here shortly. They're labeled according to what surface of the body is closest to the IR. Now, they're not only always 45 degrees. Back to the 45 degrees, obliques can be arranged from 5 degrees all the way to 70 degrees on the obliques. But the most commonly angled oblique will be 45. That's the most commonly used obliquity.
From
45
5 to,
degrees.
sorry, from
From
5.
5 all the way to 70.
5 to 70 and 45 is the common.
45 is the most common, correct.
So 5 to 70.
5 to 70, yes.
So axial and oblique are not the same, right?
The axial refers to angling your tube. Oblique means I'm angling the patient. Good question. All right, so looking at that beam, be careful, look at this closely. What kind of projection are we looking at here?
With the
It's a skull.
The first one
The first
is
one?
oblique and the straight one is
Tangential.
So this is going to be an AP axial, not oblique, because we're not obliquing the patient. What are we doing? We're angling the tube. See how the
tube.
line is going at an angle? That means that's an axial projection, but we still use AP or PA. The skull is up. We're looking at the tube, therefore AP axial projection. Y'all see that?
So what would make it a tangent?
Right there. That's the next one.
There we go.
There's your tangential. That means we have the skull tilted. Tilted. See how the skull's tilted? And it's hitting that curved surface of the side of the face. That'll be our tangential projection. It's gonna be hard.
So when it's only axial, it's only referring to the rays, to the CRs.
Correct. AP axial means that the CR has been angled,
Yeah.
not the patient,
And
just
if the patient
CR.
is angle is tangential.
If the patient, well, not exactly. Tangential refers to a specific part, like especially the skull. Most of your tangentials refer to the skull. It means I'm hitting that curved surface of the skull because I tilted the skull. Tangential tilt. That's the way you can remember that. Tangential tilt. Obliques mean I have angled the patient's body, like I'm putting him in an oblique position. We're gonna get more to that here in a second. So look closely at this. What kind of projection is this? Someone already said lateral. You see why it's a lateral?
Yes.
This is from the side.
It's coming from the side and exiting the side, so it's a lateral projection. Specifically, what lateral is that?
Or
The second one or the
That's
first?
The right
Left-
is towards
a
the
left-
bucky,
a
so
left
it's the
lateral.
right, it's the anterior
It's the right lateral,
posterior.
but-
Correct. This would be a right lateral projection. Why? Because the
Right.
right side is what's closest to the IR.
Right.
So the side closest to the IR identifies which specific lateral you're doing. Right side's touching the bucky, right lateral projection. Make sense? What about this?
RP.
This is lateral also, and the right side is touching the table, so.
PA oblique projection.
Mm.
So path of the beam is still PA, it's entering the back, exiting the front. Patient is angled, so it's an oblique projection. PA oblique projection.
Like RAO.
So that's position. We're focused on projection right now. I'm glad you said
Oh,
that.
okay.
Don't mix those
Yeah.
up. That's why I said people mix those up a lot. This is a PA oblique projection. If we're talking about position, yes, RAO.
Okay.
We're coming up to that next.
So I have a question.
Yes.
The top and the bottom are both obliques, sir.
Yes, they are.
So
They're
that
both
means
the
you
same.
look at the
Was
top
like
picture to figure out
interior
what it is,
oblique.
And
Well, you can
Because
see
this
it on
could look
both.
like lateral if we didn't have the top one.
Correct, you can see it on both, it's
Right.
just looking from the head, looking from the side. It's the same thing that we're looking at there.
I have a question.
Yes,
What did you say about the position?
the position will be an RAO. We're getting to that next. Right now, we're
Is
just
that
doing
the
projections.
Same thing as Tim's position?
That's coming, y'all jumping ahead. I'm glad y'all been reading ahead, though. That's coming up next.
Is that what the Tim's position is?
This is not
So-
Sims. This is similar to a Sims, but not exactly. This is an REO.
It's right anterior oblique.
Now we're gonna get to positions. Y'all really excited about these positions? Here we go.
Yeah, we know some, we
scared
have
for
it.
But do projections make sense? Projections, once again, path of the beam, guys. Path of the beam only on projections. Positions, how is my patient actually positioned? So, these are the 5 most common general body positions. Upright. Also can be called erect or vertical. That means the patient is standing up or sitting up in a chair. Please write that down. Standing up or sitting upright in a chair or bed, they're still upright positions. Means that my torso is vertical. Seated means I'm sitting in a chair. Still considered an upright position, a little bit of overlap there. Now, recumbent. This one people always tend to mix up because recumbent is the general term for lying down in any position. I can be lying on my back, my side, my belly, obliqued, whatever. If I'm lying down, period, it's always a recumbent position. But I can specify the recumbent position because if I'm lying on my back, I'm supine. If I'm lying on my belly, I'm prone. Does that make sense? So overall, in general, lying down in any way, shape, or form is recumbent. Specifically, on my back, I'm supine. On my belly, I'm prone. Now watch what I'm going to do here. Let's see how well you listened. If I am lying supine on a table, what would be the projection?
AP.
No, PA.
PA.
AP.
P.
AP.
So you
Because
got-
if I'm supine on my
Because
back,
you're on your
right?
back.
Where's the 2?
Oh,
Two
that's
for
right.
both men.
Y'all see what I
And
did
it's coming
there?
down.
Got it.
It's an example of a critical thinking question there, guys.
Ooh.
You don't like that? We gotta learn it though. So in reverse, another great question. My patient's lying prone on the table. What would be the projection?
PA.
PA, sir.
PA. Write those down, guys. Write those down. Some great example questions. Very good. So, what position is that patient lying in?
Supine.
Supine, so it is.
But also what? Supine,
Recumbent.
but also recumbent. It overlaps. So remember, lying down in any way is recumbent, specifically supine. What would be the projection?
AP.
We have 3 questions at once there.
Recumbent spine.
How about this one right here?
This is prone.
PA. Prone.
Recumbent.
Recumbent.
Prone position, also recumbent. It's
And
recumbent's
PA.
the general.
Mhm.
PA projection, path of the beam. Is it clicking? You seeing that? Anyone confused on that?
It's clicking, but I don't know where.
So if you're laying
If you're lying down in any
Any
way,
kind of way.
it's recumbent.
any position,
Any position, that's the general overall term, recumbent. But specifically, we can categorize the recumbency in supine, prone, and a few others that we're gonna look at moving forward, like your Sims that you brought up, things like that.
So on the test question, will they like projection? I mean, yeah, projection of beam or.
This is why I want you to look at keywords. When you're reading those questions on Friday, make sure, am I asking for a projection or a position? Read it carefully. Don't just choose an answer because you're gonna see all the choices in there being projections versus positions. You gotta read and look for that keyword. Is it projection or position? That's what's gonna lead you to the right answer. Yes?
So are you gonna put like both answers?
Yes.
You know it,
So
girl.
are you asking for a general or a?
I will be, that's why I want you to look at keywords.
Okay.
Your answer to that question will be in the question. Look for the keywords. Is it general? Is it specific? Is it position? Is it projection? Things like that. Those are your keywords you need to look out for. Am I looking for a body plane? Because that's your sagittals, your things like that.
You just read it.
Don't panic. You can do this.
Yeah, I'm gonna need a picture.
Projections
Make
of
sure you
the
put the
ray.
pictures on there.
The projection is for the race, CR,
So,
right?
yes.
And position is for the
The
patient.
patient, correct. Y'all can do this, guys.
Are you
Don't overthink it. Your answer is in the question. I'm telling you. If you read your question carefully, you'll find the right answer. Trust me.
Is the question gonna have pictures in it? Like what?
Some will, yes. Some will have pictures. Some will just be. Mr. Vaughn, did he lie to y'all?
Oh, yeah, he lied.
He said what?
He said that his review was not like the test.
Oh,
At all. At all.
At all.
well, my review will have some similar questions, but also some different ones. We'll get to that. Let's keep going. Trendelenburg. These are more general, specific body positions. Trendelenburg, we're supine with the head lower than the feet. In other words, the table is tilted so the patient's head is low and the feet are high. I got a picture to show you on the next slide. The opposite of that would be the Fowler's position. We're still supine, but now the head is elevated and the feet are lower. Sometimes that's called a reverse Trendelenburg. Now, let me go back. These are both supine. They're also both what? Recumbent. What would be the projections for those two?
AP.
They're both still APs.
Yeah, AP.
They're still both APs.
Would they be oblique?
Not on these, no, because we're just tilting the table. I got some pictures to show you. Then there's the Sims position. This is when the patient is recumbent. The patient is lying on their left anterior side, specifically can only be left anterior, with the leg extended and the right knee and thigh partially flexed. Sounds complicated, but I got a picture to show you that as well. Why do we do this position? This is done for a specific type of exam in radiography, for our BE exams, barium enemas, when we're inserting a barium enema tip into the patient. It relaxes the sphincter to allow that tip to be inserted more easily. Now you're probably saying, oh my God, I didn't sign up for this. You mean I gotta insert stuff in people's bottoms? Yes, you do. You gotta insert tips into rectums. Yes, for barium enema exams. It's not that bad, trust me. Sounds terrible, but it's not that bad. If we got time, remind me, I got a really funny story on that to share with y'all in the class. Of my first day as an X-ray tech, licensed. Don't let me forget.
So for barium and enema, you would use the Sims position. Is that what you
Or
said?
insertion of an enema tip. Yes. Now what do these look like? Let's take a look. Over here on the left, that's our Trendelenburg. See how the head is lower than the feet? The table is tilted. The opposite would be our reverse Trendelenburg, also called the Fowler's. The feet are lower than the head. These are still both supine, and these are still both recumbent. If I'm talking about projections, they both would be what? How would be the what would be the projections?
AP.
Still AP, anterior, posterior.
But
Y'all on board?
if she was outside, like laying on her stomach, it would be PA.
It would be PA, yes. But typically, these are going to be done AP, supine. These
So
specific
you don't,
ones.
they don't do prone on
A doctor may request it, but according to the text, this is the only way you should do it. So stick with this. Yeah, you're going to see different stuff, but stick with what the text is saying for your exam. There's your modified Sims projection, or position rather, Sims position. Once again, for insertion of the enema tip into the patient's rectum, it relaxes the muscles around that area, allowing for easier insertion. Yes, you all have to do that. It's not that bad, I promise you. You're all looking at me like I'm crazy. I promise you it's not that bad. All right, a couple more, guys. We have the lithotomy position. This means the patient is supine, once again, supine only. Knees and hips flexed and the thighs are abducted and rotated externally. I have a picture to show you if that doesn't make sense. They're supported by ankle supports. This is done primarily for urinary examinations, specifically mostly done in surgery. And then the lateral position means that the patient is lying on their side or standing with their side against the IR. They can be the right or the left side, and we name that position according to the side closest to the IR. So if the right side is on the table, it's a right lateral. If the left side's on the table, it's a left lateral. If I'm standing with my left side touching the IR, left lateral. If I'm standing with my right side touching the IR, right lateral. Those are all lateral positions. So we can have an upright lateral. We can also have a recumbent lateral. You'll see what I did there?
Yes,
Does that make sense? Excuse me. Now, when it comes to positions and projections, guys, this is why you gotta be careful with your key words. Lateral can refer to a position and a projection. They use the same word for both. That makes sense? You have a lateral projection, also a lateral position. They both use the same word. Did Mr. Fawn use any of that terminology for y'all yesterday? Did he throw some proximal and distals at y'all? I told him to. Make sure y'all were paying attention in class. Coffee's terrible today. Ugh.
Do you make it here or you bring your own?
I bring my own. I make super strong coffee, so I gotta have my own brew. But it's just not doing it for me today. This is pecan coffee. It's not very good. HEB. I don't know. It's just not, I usually love HEB brand. That's not doing it for me today. It's just a little funky. God, all right, guys. What specific position is this patient in? We got multiple words we can use. What lateral specifically? Right lateral, because the right side's closest to the IR. Also, upright lateral, because we're standing. Upright, right lateral. Upright, right lateral. How about this one right here?
That's shoulder.
Shoulder.
A shoulder.
So it's opposite of the other.
That's
Head
a
down,
lateral.
head down and the leg side.
Well, I'm not asking for the part though. I'm asking for the position, guys. We're not to this yet. This is Rad Pro 3. It's an L spine radiograph.
Left lateral.
What is that? Okay.
A left lateral, but what specifically? Recumbent left lateral, because we're lying down. Make sure you look closely at the difference. One's standing, one's lying down. Upright right lateral on the left. Recumbent left lateral on the right. Does that make sense? There's the lithotomy position. These are commonly done in surgeries. These are mostly for your urinary type cases. It's characterized by the stirrups, having the legs up and out of the way, so that they have easier access for the study. Now, you're saying, what would I be doing on this? You'd be in there with your C-arm. Have you guys seen the C-arms yet? You'll see them soon. That's a surgical fluoroscopy X-ray device. You'll go in with that. You'll do imaging over the patient while they're doing the surgical case. So there's a lithotomy position. Also, what else is it? Recumbent and what else? Supine. Supine, recumbent, lithotomy. What would be the projection if the
AP.
IR was under here?
AP.
Is it making sense?
Mm-hmm.
How about this one right here? This person can't stand.
Upright.
Still upright,
Left.
seated,
Left lateral.
left lateral. Very good. What's the projection?
Lateral.
Still lateral. Still lateral. So we're entering the side, exiting the side. Now let's get to those nasty obliques. All right, they're not that bad, guys. So when we specify an oblique, we're specifying the positions now. We use 4 abbreviations down here on the bottom. And we're going to name it according to the side or the surface closest to the IR. Closest to the IR, whether we're talking about the table or the wall bucky. Now the rotations do vary. It depends on what anatomy we're looking at. Once again, the most common type of oblique position will typically be 45 degrees. And there's our abbreviations: RPO, LPO, REO, LEO. If you know the full words, you can figure out exactly how that position looks. Listen closely. Before I show you the pictures, I want you to think to yourself, right posterior oblique. What do you think that means? Talking about a position, right posterior oblique. We're naming it to the surface closest to the IR.
Right side.
Right
Posterior.
posterior. Right posterior right side's touching the IR. LPO, left posterior oblique. What am I doing? Left posterior side touching the IR, whether I'm standing or the table. So what would be the REO and LEO?
Right
Right
interior.
LEO, left anterior oblique. What am I going to do?
Left side touching the.
Left anterior surface touching the IR. REO, right anterior oblique. What am I going to do?
Right anterior touching the eye.
Right side touching the IR, anterior surface. Does that make sense? When you say that full word, it's going to help you figure out what you're looking at and how to position your patients. Don't rely just on the abbreviations. People tend to get more confused if they just look at the abbreviations. Write out that whole word. It tells you exactly how to position that patient. Does that make sense? So then what would these be? Let's start up on the top left. What is that?
Upright.
Left.
Let's just talk about the obliques. Don't worry about the upright and the supine and all that. Obliques first.
LPO.
Posture.
This is an LPO. Can we see why it's an LPO?
Left
Yes,
LPO.
His
is-
left posterior surface is touching the IR.
That's
What about on the right side?
Right.
RAO.
Anterior.
Right anterior, very good. Right anterior. Let's go to the table. How's this patient lying?
Left.
LPO.
Posterior.
Left posterior, LPO, because the left posterior surface is touching the table. And what about this one here?
Right
RAO.
anterior.
RAO, right anterior. You see how all these have the patient turn in different ways? Be careful. Be careful. Look closely. What surface is closest to my IR? What surface is closest to my table? That's going to determine my exact position on those obliques. Now, we got more overlap because this is LPO, but what else is this?
Upright.
Upright. What would be the projection on this one?
anterior, posterior.
AP oblique. For obliques, you name it AP oblique or PA oblique for your projection. So AP oblique projection.
Oblique.
LPO position. Y'all see that?
Oblique for what, sir? Anterior, posterior.
For your projection. So I'm saying how you got projection versus position. LPO position, AP oblique projection. Because of path of the beam.
What
So-
planes are they working on?
Say again?
What plane are they working on the first one?
What plane are they working on?
Like,
Combination of both. MCP and an SP.
So why is the AP projection, AP oblique position?
So when you're talking about projections, be careful. If it's an oblique position, it's gonna be an AP or PA oblique projection.
Why is it, oh, because we can't see it on the picture, right? It's oblique,
Correct.
sir? We cannot see it, that's oblique. But you
Well,
said
you
that
can
was
see
a,
it. You can see it's oblique.
because,
I'm just saying for projection,
yes, for
once you get
projection.
path of the beam, if the patient's body is oblique, when you label the projection, you have to include the word oblique in
Oh,
there.
I see. So if the patient is oblique, then the beam is also oblique.
Well, the beam is not.
No.
It's traveling through the patient who's in an oblique position. That's just how you label that projection, if the patient's obliqued. So, let's just go through them again.
I see.
Let's go through position. Once again, guys, position here. What's the position? Specifically, upright,
AP.
LPO, left posterior oblique. What would be the projection? AP. Oblique projection. On the top right, upright what? RAO, right anterior oblique. What would be the projection?
PA.
PA oblique projection. Good. We are recumbent. What's the specific position?
LPO.
LPO
LP.
position.
But-
Left posterior surface is
Yes,
touching
sir.
the table. What will be the projection? AP oblique projection. And last one on the right here. What would this be? For recumbent, right anterior oblique position. What's our projection? PA oblique projection. To make it a little more sense. All right. Let me do one more demonstration because I'm not convinced yet. Come up here, Shaji. Is it Shaji or is it John?
John's.
John, is that your first name?
Yeah.
Okay. John's just a really good name. to be honest. Next time, yeah, I'm used to a first name having the S on it, but great. Okay, so John's here. He's standing upright. This is our IR, right here, our image receptor. I'm gonna put him in an LPO. I'm sorry, RPO. Why is it RPO? His right posterior surface is touching the IR. Path of my beam goes this way. Entering anterior, exiting posterior. So this is an anterior, posterior, oblique projection. It's an RPO position. Make sense? Let's turn him this way. He's now in what position?
Right anterior. Oblique.
Left,
Oh, I'm sorry.
left, posterior.
Remember,
ob-
don't get, it's easy to think reverse because you're looking at him. But anatomic position, LPO. His left posterior surface is touching the wall. Path of the beam,
It's AP oblique. sir.
AP oblique projection.
AP oblique projection.
Turn face the wall for us, Johns. I'm now gonna put him in this position. What position is he in? RAO position, also upright by the way. Beam, what's the projection?
PA or
PA oblique projection. And then finally, what position is he in? LAO. And what's the projection? PA oblique projection.
So
When
PAO
you're-
is PA oblique possessions.
Say
Or
again?
PAO is PA oblique possessions, projection.
PA oblique projection, LAO position.
Oh, so
Now,
the-
when you're studying this, guys, when you're studying these positions, do it on each other. Or your family at home. That's the easiest way to remember these if you actually actively perform these. Whether we're talking about the recumbent, the standing, put them in all the positions and name them. Name the position, name the projection. It'll help you recall it for the test. Make yourself a picture as well. You can sit down, Johns. Thank you. Does that make it a little more sense though? I know it's confusing, I know it's hard, but practice these on your partners, practice these on your family at home. That's what I used to do with my mom and dad when I was in school. I was moving them all over the place when I studied for these tests. It'll help you, I promise you. Let's move on. We already named those. It's a duplicate, sorry. Hello. Ah. Oh, goodness. What's going on here? I hit it too hard. Okay. A few more positions, guys. We have our decubitus positions. When you see the word decubitus, key word. Every question you get on decubitus will typically include this statement right here. It exhibits a horizontal central ray. That means that the central ray is going horizontally with the patient on a table. I'll show you what that looks like in a second. Horizontal central ray. Patient will typically be on their side, their back, or their belly. So we have a little overlap there with the supines, the prones, and the laterals. But decubitus is unique in that it exhibits a horizontal central ray. I'll show you what it looks like if that doesn't make sense. Then lordotic, that's going to be when the patient is upright and they're leaning backwards. Some of you have practiced that in lab yesterday. Some of you practiced the cubes as well. Lordotic means the patient is standing upright and they're leaning backwards. Based on what you know, if I was to give you a question that looked like this right here, upright position in which the patient is leaning backwards, what's the only projection that could be?
Yeah, AP.
Why?
That's the ray that's going to the front and punching off the back.
Exactly. If we're not going to have the patient facing the IR and lean back like this. We're going to fall backwards. So that lordotic will always be AP because the patient's always going to be leaning backwards towards the IR. So that was a good example question there. Critical thinking once again. So decubitus. Right here, the patient, both these patients are in the lateral position. Y'all can see that, right? But what is unique? See how the beam is traveling across the table horizontally? That makes it a decubitus position. Once again, keyword, if it exhibits a horizontal central ray, it turns it into a decubitus position. This specifically will be a left lateral decubitus because the left side is down. Just like a left lateral we talked about before. Left lateral decubitus. On the right, it'd be a right lateral decubitus because the patient's right side's on the table. And we're going to have two more we're going to talk about that are based on whether the back or the belly is on the table. These are our laterals. Left lateral, right lateral decubitus. Some of y'all did this in lab yesterday?
Yes.
Good. Good.
So, just to confirm, the body part touching the table is what's named for, right?
Correct. Correct. You're still basing it on what's touching the table, on the decubes. Good question. Now, if I asked you what projection is this?
AP.
Very good. Y'all see why it's an AP?
Yeah.
Because we're entering the anterior, exiting posterior. What would this be? Very good. Very good. Why do we do this, by the way? Why would we do a decubitus chest?
Why wouldn't you do it standing up?
Well, I'm asking you. Why would
Here.
y'all tell me. I don't know. Why would we do this?
So the fluid can go
Anybody
up?
read ahead?
Is it because the fluid can go up?
Very good, because of fluid. So typically if a patient has fluid in the lungs, we'll have them lie on their side like this to check the fluid level, see how they fall in the lungs. Not the only reason we do it, but the most typical reason we'll do that. Now, two more decubitus. Once again, it's exhibiting that horizontal central ray, but we've changed the position. Whoops. We've changed the position. This patient's lying on their back. Therefore, this is going to be a dorsal decubitus. When we talk about dorsal and ventral, dorsal decubitus because the dorsal surface is touching the table, or the back surface. Versus, this will be a ventral decubitus because the anterior surface is touching the table.
So this is
Still
left.
horizontal. Yes?
So it says now anterior decubitus and posterior decubitus.
No, it won't be anterior posterior. It's labeled by dorsal and ventral. Good question. Dorsal when the back side's touching the table. Ventral when the front side's touching the table. But only if it's a horizontal beam. If we were going straight down like normal, that would be PA, that would be AP. Y'all see what I'm talking about? It's all about that horizontal central ray that changes it to a decubitus. So, what projection would both of these be? They'd both be lateral projections. Why? Because the beam's entering the lateral side, exiting the lateral side, even though we're doing it cross table. Does that make sense?
Is that a marker?
The left one is dorsal or ventral?
This is dorsal, because the back is touching the table. Ventral would be when the patient's lying face down with the belly touching the table.
Not even the.
You always wanna mark the side that's closer to.
You will mark the side closest to the IR, correct. We'll talk more about that in positioning when we get to the chest chapter. And finally, those of you that were in lab, what position is that?
Lordotic.
That's your lordotic, because it's characterized by the patient leaning backwards, but what projection would it be? Still an AP projection. Y'all are doing much better than the last class on this, I gotta say. So very good, very good. Let's review. What position is that patient in?
Oblique, it is for sure. And then it is from.
Louder, we're gonna put you.
RAO.
RAO, right anterior oblique position. Y'all see that? What's the projection? PA oblique projection. What is this? All those choices. It's a decubitus. If we're gonna be more specific, what specific decubitus is that? Left lateral. Why? Because the left side is touching the table. What's the projection? AP. So ask you 3 questions in that one image right there. AP projection. Once again, guys, look at the key words. If this was your test question, see how you could mix that up? What's this asking for?
Projection.
So the correct answer would be, how many of you would have jumped and chose that right there? I'm warning you guys, be careful when you read those questions. Look for your key words. What am I asking you on that question? That's why I always say read it 3 times before you make an answer. Trust me on this. What's the position? Left lateral decubitus. Now see how tricky this is? We got left lateral, we got left lateral decubitus. This one is decubitus because we're using that horizontal central ray. If they were just simply lying on the table with the tube above them, it would just be a left lateral. Y'all see that? All right, last part of the chapter, guys. We're gonna talk about some body movement terminology because we have to learn how to move body parts in different ways. Now, we're not going to use these in front of our patient. You're not going to tell a patient to abduct their arm. They'll probably look at you like you're crazy. But we need to know the actual scientific terms in case a doctor, physician asks us to do this. In any case, first one, abduct or abduction. No, it doesn't mean that aliens are taking you away from the planet, but it's a similar concept. It means the part is moving away from the central axis of the body. If my arms are by my side and I move my arm like this, it's going away from the center of my body. It's abducting. It is kind of like an alien invasion, you know, they're abducting you away from Earth. Your body's Earth, your arms are going away from Earth, abducting it away. What's adduction? It's the reverse. If I bring it from the outside and bring it towards the center of the body, that's adduction. Very similar words. Make sure you look at those closely on the spelling. Abduct, adduct. Abduct, adduct. If you gotta do this stuff for your test, I'm not gonna look at you crazy. Move your arms around, do the motions, it's gonna help you, trust me. Extension means I am straightening a joint. Easiest example, the elbow. If I straighten my arm out, I'm extending it. If I bring it up, flexion, like you're flexing your muscles, right? Extend, flex. Straightening versus bending.
Is that the only 2 examples of your arm? Your
Well, no, you
leg?
can flex and extend multiple parts of your body. You know,
But-
spine, legs, arm, but easiest to remember is the arms.
And your finger?
Fingers, yeah, another one. Flex, extend, flex, extend.
The neck.
Flex, extend. Then we're gonna have some hyperextensions on we're gonna talk about here in a second with the neck specifically. So there it is right there, guys. Abduction away from, adduction towards. And there's some flexion and extension examples, leg and arm. Okay, a few more here, guys. Hyperextension versus hyperflexion. So, it's the more extreme versions of what we just talked about. Hyperextension is an excessive extension. Hyperflexion is a forced overflexion. And that's usually going to apply to our spine. I'll show you examples of that here on the next slide.
Only to the spine, sir?
Not only with the spine, but most commonly with the spine. Evert, eversion versus invert, inversion. Refers only to the foot and ankle. When we evert or eversion a foot, we're turning the foot outward. Move your foot outward like this. That's eversion. Inward would be inversion. Eversion, inversion. It's only for foot and ankle, by the way, guys. Eversion, inversion. Usually that will apply to what we call stress view ankles. The doctor requests a stress view on an ankle to check the integrity of the joints. They'll do those inversion and eversion movements on the ankle and take some x-rays.
So you said stress view images. No, you said the stress view what, sir?
Stress view ankles.
Ankle. Stress view ankle is an image of the ankles.
It's a specialized view of the ankle that the physician requests if they're scared, that, if they're wanting to do a bit further analysis of the ankle joints. But that's Rad Pro 2. We'll come back to that. I'm jumping way ahead. There's an example of your hyperextension versus hyperextension. I'm sorry, hyperextension versus hyperflexion. I should say flexion. I apologize. Hyperflexion is when you bring the neck forward like this. Hyperextension is when you bring it back like this. It's an extreme flexion, extreme extension. When we're talking about the spine, guys, extension means that we're going backwards. Flexion means we're going forwards. Easy to mix those up. When we're in a neutral stance, like the way you're all sitting right now, your neck is naturally in a extension type of motion. It's naturally extended. When we bring it forward, it's a hyperflexion, backwards, hyperextension.
So you say that it's not the same for the spine, it's opposite of what's for the head?
Well, don't worry about the head at all. Just focus on the spine.
So did you say head backwards, it's,
If I bring my head backwards, my neck is also going backwards. It's a hyperextension. If I bring my head forwards, my neck also goes forward. It's a hyperflexion. So flexion means forward, extension means backwards on the spine. Easy to mix those up. And there's your inversion versus eversion. Eversion, once again, means outward rotation. Inversion is an inward rotation of the foot or ankle. So this would be a what? Eversion. This would be an inversion. All right, so pronation and supination actually sound very familiar, but we're talking about the actual palm here, or the forearm. When we pronate the forearm, it's called a pronation. That means the palm is down, so your hands are like this. There's a pronation of the forearm. Supination means palms are up. Once again, anatomic position. That's why we name it like that. Palms up, supination. Palms down, pronation. Then rotation, that can refer to any part of the body that we're turning around on its axis. We have what's called a medial rotation and a lateral rotation. Most common one that we will talk about soon will be for the shoulders next semester. If I have my hands in anatomic position and I rotate my hands like so, this is an internal rotation. If I go back to anatomic position and I rotate it outward, that's an external rotation. Internal rotation, external rotation. Does that make sense? Internal, external. That can apply to any part of the body, but we'll most commonly use that very soon next semester with the hands when we're positioning for shoulders.
In college, they showed us when they're laying supine, it's like they're holding a bowl of soup. On that.
That's pretty good. I like that. Did y'all hear that? When you're supine, you're holding a bowl of soup. Soup, supine. It's pretty good. I don't have to use that. That's good. I like when you guys come up with those little sayings. Always remember them. They're really good to use. So there's your supination versus your pronation right there. There's a lack of soup in that palm, but
Say
So now you won't forget it. Glad you brought that up.
money,
What'd you say?
money.
Oh, money?
Put that money there. Yes,
You gotta be supine to do the money?
yes.
And there's your medial rotation versus your lateral rotation, showing you the arm there, the hands. Medial, lateral, medial, lateral. Medial's towards the body, lateral away from the body on the rotation. Circumduction. We're almost done, guys. Almost there. I know y'all sick of vocabulary words, but we're almost done. Circumduction means a circular movement of a limb. So I can take my hand like this, and if I draw a circle, this is circumduction. How else can I do that? I can do my foot in a circle. Circumduction. I feel like I'm doing dance moves up here today. All this stuff. Circumduction. I can also just do my finger with circumduction like this.
What about your dad?
Huh? Oh, your head? Yeah. Yeah, your head as well. Yeah.
The
That'll make you dizzy though. Don't do that too.
ellipsoid is also circumcision.
Say again?
Ellipsoid joint.
Ellipsoid allows circumduction. Yes, very good. Very good. Tilt is a tipping or a slanting of a body part slightly. The most common body part we tilt is the head. We do head positioning. What's a head tilt? Like this. Like this. You know, when your dog looks at you curiously, you say something, they tilt their head at you. Head tilt. And deviation is a turning away from the regular or standard course. Deviation, for example, if I deviate my hand, I'm turning it this way. The normal position is like this, I'm gonna turn it away. That's a deviation. I can do the opposite, deviate, deviate. That's the most common deviation we do is the hand and wrist. Like you're waving, you're deviating your hand when you wave.
So would it be like a increase, would be like inward and outward too? Or-
Good question. So we're gonna label that according to the bone that we're deviating towards on the wrist. The ulna is on the pinky side, so this is an ulnar deviation. The radius is on the thumb side, this is a radial deviation. That's Rad Pro 2 as well. Say again?
Can you do that with the foot too? Does that apply to the
For the deviation, no. No, it's typically just gonna be on your wrist. The foot's gonna be that inversion, eversion. Good question. There's that circumduction. It didn't include your neck one, I'm sorry, but that is a circumduction as well. There would be, so I didn't include the word rotation, but usually you talk about rotation versus tilt on the head. Once again, tilt's when I tilt the head like so. Rotation of the head would be like this. And you're saying, no, Mr. Donahue, no more vocabulary. Please, no more.
That's rotation, so no.
Rotation's on the left, tilt is on the right. So tilt means I'm tilting the head like so. Tilt. Rotation means I'm turning it like so. And there is that deviation once again. That's your radial versus ulnar deviation. Once again, when I radiate my wrist, or I'm sorry, when I deviate my wrist towards the pinky side, that's an ulnar deviation. Towards the thumb is a radial deviation. It's named according to what bone we're turning the hand towards. And then we have elevation versus depression. Another depression again. Feeling depressed? All this vocabulary. Don't feel depressed. Y'all can do this. It's gonna be all right. So when we talk about depression, we're talking about the shoulders in radiography. We either elevate the shoulders or we depress them, depending on what we want to look at. Elevate the shoulder means that they scrunch the shoulders up. Depress means that we relax the shoulders. It's gonna feel like you're really depressed and you're hanging your shoulders down. Hopefully we're not walking out of the room on Friday looking like this. I want you to walk out like elevated, like, man, I knocked that test out of the park. That was awesome. Elevation versus depression. And that's the end of chapter 2. Okay, guys, take a